These are my disclosures, none of which I think are really relevant for the talk this morning. Other than that, I absolutely hate amputations, and that is a disclosure that I should include as well. You know, how big a problem is peripheral arterial disease? Well, the Partners trial told us it was pretty big. Simple screening was done on patients over age 50 with diabetes mellitus or who had smoked, or over age 70 just by virtue of reaching that age. 29% of those people had a diminished ankle brachial index. That means at least 29% of that group had PAD. Because understand, this is a very specific test, but it's not totally sensitive. And this may have missed many patients with advanced peripheral arterial disease. And interestingly, roughly half of these patients and those that underwent screening had evidence of concomitant coronary disease. Now, what was interesting is that very few of these patients, as a percentage, had typical claudication or had other symptoms. They had symptoms which were ascribed to other causes, causes such as arthritides or getting old. And you may say, so what's the big deal? Why make the diagnosis? Well, this is why you make the diagnosis. Sick legs are almost never attached to healthy patients. And what happens is, as ankle brachial index falls, so does life expectancy. So here we can see, even in an asymptomatic cohort, if we follow ankle brachial index down to 0.8, that has a worse prognosis than breast cancer. A worse prognosis than breast cancer. But if we follow ankle brachial index all the way down to 0.4, where it frequently is in critical limb ischemia, that carries a prognosis as bad as the worst lung cancers. So even if a patient is not symptomatic from the peripheral arterial disease, it is important and in fact imperative to make that diagnosis because that's a high-risk patient. That patient should be on antiplatelet medications, should have supervised exercise programs perhaps, should have their cholesterol lowered, their blood pressure controlled, regular follow-up, screens for carotid disease, perhaps a calcium score to determine if they have underlying coronary disease. You can put your finger on everyone's foot pulse, but you can't do that on the heart. So if you simply take the time to feel foot pulses, and if those foot pulses are absent, you've identified a high-risk patient, and you may have saved someone's life. Now, on the far end of the spectrum, not just the claudicant, is amputation. And at the very best centers in America, the outcomes of major amputation are terrible, and they're worse in most community hospitals. Yet somehow or another, we've not looked at amputation as this terribly disruptive force that it is. At the best centers in the United States, a below-the-knee amputation has between a 5 and 8% 30-day mortality. And above-the-knee amputation, between an 8 to 12% 30-day mortality. A third of major amputees who have their amputation not from trauma, but from atherosclerotic disease, are discharged to nursing homes. Many of them will never leave those nursing homes again at an average cost of about $140,000 a year. Only about half of those that have a below-the-knee amputation will get a prosthesis and walk again, and only a quarter of those who have an above-the-knee amputation will get a prosthesis and walk again because they're old, they're weak, they're infirmed. And the quality of life is terrible. So amputation is more expensive than limb salvage. It's more morbid than limb salvage. It has a higher mortality than limb salvage, yet it is the first option given still to the majority of patients presenting with critical limb ischemia. We have to change that. Now, even if you say, well, I don't really have all the interest in the legs, why must I address the peripheral vascular space? It's because it affects so many things. So this was a 45-year-old man who was referred for bypass surgery from an outside hospital. He was known to have high-grade brachiocephalic lesions shown on the left, Known to have high-grade left subclavian lesion shown on the second picture, high-grade iliac disease in the third, and renal artery disease shown in the fourth picture. Now, why is this important? Can't measure pressure in the right arm, can't measure pressure in the left arm. The patient's left carotid totally occluded. So blood flow to the brain is only via the right carotid and right vertebral, both of which are getting there through this highly stenotic innominate artery, and blood flow to the left side getting there via the vertebral, which has to get there through this subclavia. This is a young man. If he's going to have bypass, what kind of conduit do you want? An artery, an internal mammary artery. Problem is, if you use the internal mammary arteries, they're beyond a stenosis and they're not adequate. So this patient developed crushing chest pain upon arrival, and the nurse called me frantic. I was in the cath lab finishing a case. She said, the pressure's 50, the ST segments are going off the chart, the patient's diaphoretic, what should I do? And I said, please give nitroglycerin. I'll be right there. She says, I refuse, and she hung up on me because she said the blood pressure was low. She hung up before I could tell her she was not measuring a good blood pressure. I ran there, we gave nitroglycerin, the patient's symptoms abated. The nurse and I had a conversation about not hanging up on each other. That's not appropriate. And we then went on to treat the patient. Coming from the right radial, you can see why she couldn't measure pressure in the right arm. Just the wires wholly occlusive of this very large innominate vessel. And it had 140 millimeter of mercury gradient. So we stented this. Now we've established flow to the brain. Now we can measure pressure in the arm. Now the right internal mammary can be used as a conduit. We turned our attention to the other arm. And what we then did is, here I've dotted through this already with a support catheter. It was a little difficult to cross, but still there was a large gradient and still a high-grade lesion. So we stented this. Now we can use the left internal mammary, which you see lighting up well in this subsequent picture. We can use it as a conduit. Now the patient's getting blood flow to the brain via this vertebral. This patient the next day had an uneventful surgery with a lima to the LAD, a rima to the right. The circumflex was left for angioplasty because the patient had a porcelain aorta, and the surgeon did not want to have to cross-clamp the aorta. This patient went home 2 days after that surgery. This is the kind of a case that almost certainly is a mortality if you can't address these issues. Or what about this man? He was my age when I worked on him, 51-year-old man with severe coronary artery disease. I'm not 51 now. We were both 51 at the same time. Requiring CABG, peripheral vascular disease with claudication, and something I always ask a claudicant, are you impotent? Men don't like to brag about that, believe it or not. The cardiovascular surgeon, as every cardiovascular surgeon I've ever known, wanted to operate stat. You always want your cardiac surgeon to be the kind of guy that wants to operate stat because often they need to. But I suggested we at least assess anatomy because this patient did have claudication, and sometimes that affects what we can do surgically. So here you see the CT. On the left, you see that the right common iliac is wholly occluded with distal reconstitution of the common femoral. On the left side, you see the common iliac is patent, but the external iliac is wholly occluded. But perhaps from a prognostic perspective, the more important image here is the one on the right, the lateral. Notice what's filling the legs. These are the so-called collateral pathways of Winslow, and these arise from the internal mammary arteries. Now, you may not believe that, so let me prove it to you. I did this case live for TCT, and before they came on live with the camera, I'd come from the arm. I'm going to shoot this mammary artery, and I want you to follow it with me. And you can see it's filling the leg just as the CT showed. Same was true on the other side. Now here we're doing a distal aortogram. Do you see any filling of the legs? No, right? What do you think happens if you take down this mammary and connect it to the heart? This patient now has no flow to the leg. Big problem, right? But this is a young man, and you should use an arterial conduit if you're going to do CABG. So what did we do? Well, we fixed this right side. We ballooned and stented. We turned our attention to the occluded left external. You see I have a wire across the external iliac. But notice why he's impotent. Do you see that high-grade lesion going to his internal iliac, running down towards the middle of the screen? Well, we weren't going to let that go untouched, so we fixed that too. He was my age. I thought that was something that needed to be fixed. So here you can see we're ballooning. We stent both of these. This is the final result. Now you can see that internal iliac is nice. Both iliacs are nice. But what's important, this patient had an uneventful surgery again with the use of both internal mammary arteries. Now, what do you think he was most excited about? Well, he was very excited about the fact that his surgery went well, because he was very worried and people had told him it would be high risk. He was incredibly excited about the fact that he could walk without claudication. But what he was most excited about was neither of those. It was that he was no longer impotent. Or how about this patient I showed you before? Multiple surgeries, was planning to kill himself if we were unsuccessful. MR showed no infrapopliteal vessels, patent. I told him I didn't think we could help him. He said, please try. I said, okay. Here we found that channel using a laser, and we're able to establish flow. This is obviously not the next day. This is 13 years later. I would suggest if we can save a limb like this, there are a lot of amputations going on that we might affect. So how this all played out? Well, you can see there is a little, I don't have a pointer here, but in South Louisiana, there's an area that's very red, down right on the Gulf. That's where we live. We have a very high rate of revascularization. That is a little bit unfair in that we get patients from all over the world, and so that makes those numbers look particularly high, but we do a lot of intervention. But what I am particularly proud of is if you look at this. What was once a top 10 amputation site in America is now #1 lowest in the country, and so you can make a difference. Now, what do I think it's going to take over time? It's not just advanced intervention, it's prevention. And Hoong-Dae Chang has put this very eloquently in the first textbook of medicine. The inferior doctor treats illness, the mediocre doctor attends to impending illness, superior doctor prevents illness, and we have to become that. If we look at the continuum of care, we're getting to patients too late. We're getting to them at the point where there's very little that can be done. We have to change that. We have to move things back to the left. And this is doable, but it takes effort from all of us. I thank you for your attention.